So I was going to now, I think, go to the audit report and actually show you the COPD audit report, and hopefully that's clear. So the first thing is that this is an interesting one I'm going to throw at you, Russell, actually, is this particular practice had 2% of their patients had a COPD diagnosis. What do you think about that number?
Well, I think they've missed probably about 10 to 12% of them.
And where would you look for those missing ones? Because I think that's one of the things this report will talk about. But where do you think those missing patients are going to be hiding?
Probably with an asthma diagnosis or a misdiagnosis at least. I spent one very miserable Saturday, pouring rain. I did a sort of reverse audit. Our software wasn't good enough because of our free coded data you referred to earlier. But I will look back at pull up everybody in the practice who was on Seretide or Symbicort in those days, about 8 years ago, and then went back to look at their diagnosis and spirometry rates. And the figures in the practice were terrible. We were missing so much, and spirometry had only been done in about 20 to 25% of them. So we started to pull those patients in and really work out what was going on with our respiratory disease. So I think they're hiding. They've been missed. They've been written off as infective episodes or just chest infections. But I think realistically we've got to look a lot more seriously.
So I'm with you on that. So I have to say we did a lot of work 15 plus years ago looking at questionnaires and things, case finding questionnaires for finding these patients. And somebody sent me a question in here about doing screening spirometry in all smokers. The problem is, if you do screening spirometry in people over the age of 40 with a positive smoking history, about, depending on a few factors, it's going to be about 1 in 6 patients will have COPD. We did that in Aberdeen and Denver some years ago. But what we do know now, though, is if you target those patients who are at least 50 and have had 2 chest infections in the last 2 years, half of them will pretty much turn out to have COPD. So it's a very easy group to find. And obviously one of the things the audit report does do is it actually tells you who those patients are, so that you can then think, okay, you can put a flag on their system when next time they come in, order spirometry or think COPD. So I think they are hiding in plain sight. They're not consulting. They do consult. It's just they turn up on Friday afternoon, of course, when you're busy and you haven't got time to get into the whole discussion. Can I just have another course of antibiotics, doc? They did the job last time. It's got a bit of bronchitis. And we actually found in the UK that people had missed opportunities over about 10 years before the penny dropped and the diagnosis occurred. They've been to hospital. Some of them have even been admitted to hospital. They've had lots of chest x-rays, but no spirometry. And so I think they are hiding in plain sight, and I think that's really important. The other group, Russell, that we also see a lot of, and those cases I think illustrated, there's a lot of people just on SABA only or just on ALAMA only, carrying on either very symptomatic or getting flare-ups. And again, there's about as many of those we find in the practices as there are those without diagnoses often in the high-risk group. That also happens a lot.
And I think there's an equal number of true COPD patients on LAMAs who've actually contracted their exercise and activities back to their exercise tolerance. And if they were truly doing what they used to do, they'd be a hell of a lot more symptomatic and would have been up-escalated to duals or triples later on. But I think a lot of COPD patients, when they get knocked up, they don't stop and think about an action plan or take their blue one. They just sit down and stop until the breath comes back, then they move again.
And so the action plans, Carrie will hopefully be talking about that soon when her internet gets sorted out. But what proportion of your patients would you think should have a COPD action plan or do have them?
On a tertiary day, I'd say 2/3. On my real world general practice days, I think probably 1 in 10 have actually got one. So we certainly haven't used them and picked them up as much as we have in asthma. Not that we did terribly well there either, but I think the action plans and actually the understanding of an exacerbation by a patient and by a GP needs to be upskilled. they think they should sit out there, the patients, and they only come if they've been, 3 or 4 days really crook and they really start to get short of breath and febrile and lots of bloody brown phlegm. But they should be there a lot earlier than that. And they should, those that have got action plans, I have them sitting at home with, at least with their antibiotic, and the ones I trust with their oral corticosteroids ready to go. And I want to see them early, but I don't want them sitting at home over a weekend waiting till the Mondays. I only work half days Mondays, so it's an ugly day to try and get in to see me. I think the action plan empowers the patient beautifully. And I think it could be more important in exacerbation management than perhaps asthma.
Yeah. So I've got a question here, which is really pertinent here. So what is the right time to do spirometry when the patient presents crook in an exacerbation and unable to do it? So I've had to use the word crook. I don't use that word very often. So it's not in my lexicon. So anyway, when do you, well, first of all, obviously we've got the COVID challenge right now, but assuming we don't have the COVID challenge and Australia's safe, when's the right time to do spirometry? Can we do it when the patient turns up on Friday afternoon and they've got a bit of a chest infection?
I personally don't think you should. If you want to war with your practice nurses, then try and ask them to do that. It won't go down very well. So currently you can do, there was a question earlier on that was typed in. So spirometry from TSANZ, Thoracic Society in Australia, about 3 weeks ago now, you can go with your spirometry, but they need to have a fever check before they begin. There shouldn't be any suggestion of infectivity, and you should have an inline filter at present, and they should bring their own SABA to use for their pre and post. So yes, you can do it, but there's restrictions and you should be sensible. You shouldn't be using a nebulizer to deliver your Ventolin for your pre and post. They should be using their own SABA. We've actually had a practice nurse, well, I got caught in the middle because it wasn't me requesting it, but someone was requesting spirometry every time they were sick because they wanted to know whether it was diagnostic or not. And she got 2 cases of bronchitis. She blamed on these procedures, and I think she was probably right. And I had to bring an infectious diseases specialist in to rule, and that was that they shouldn't be done when they're acutely infective. And
I think if patients are pretty sick, it's not very nice for them having to do spirometry either, let alone the infection risk. Getting people to do a proper maximal effort or continue to breathe out until their lungs are empty is very hard to do when someone's acutely sick. So absolutely, you need to wait for their well to do it. And that's where you will lose people. That's also where it's valuable potentially to have some home spirometry. I've been asked to ask Kerry if she can hear me. And obviously not, is the answer to that. Okay. The next question that's really cool is, so we're going back to the report back and forth here, but this is a very important question. And I think one that really is the nub of what matters in COPD. If we miss the diagnosis of COPD and it comes up about 10 years later, does it make any difference not being medicated? Russell, I'll give you the first go at that, and then I'll have a go at it.
I think the benefit of really early diagnosis is to try and get a better smoking cessation rate. And I know that there's the data suggesting that the biggest drop in FEV1 is in the early part of the illness, and it's a very rapid, steep decline and then scoops out a bit. But I think the real benefit of really early diagnosis is modifying lifestyle factors.
Yeah, and I think I'm with you on that. I mean, smoking cessation is clearly the most important thing we can do. Keeping people active, because it's amazing how people turn up, in a very bad state when they first get diagnosed or properly diagnosed. We do know the other thing is that lung function decline potentially is related to exacerbations. So we've just had a paper accepted that looks at the number of years people have exacerbations in their long-term lung function, and there's a strong association between the number of years they've had exacerbations and their long-term lung function. So 6 years exacerbation years is a bit like 6-pack years in terms of the extra effect it has on the lungs. So preventing those exacerbations is, I think, also important. And keeping people active and fit and trying to keep them in work and all the rest of it is all good reasons for making the diagnosis. So go back to the questions keep coming at us, so that's rather good. So somebody asked, can we just, now we've got the COVID situation, all the challenge about doing spirometry, take your point about doing it more safely. Can we not just give them a llama or anyone? What do you think, Russell?
Well, you can legally do it under the PBS. You can add Spiriva in.
Mm-hmm.
I think we still need to have the proper diagnosis. I don't think you can get away from that.
No, as I said earlier, the best we're going to get ourselves to is 50% of them will have COPD, 50% won't. The other options are, I mean, you can do homes. There is some data on home peak flow as a potential test. Not perfect, but better than nothing. And then also looking at home spirometry. There are, if patients want to buy them, or you can arrange them for patients in the UK, we can prescribe the Pico 6. It's fully reimbursed. And actually, we're experimenting with using that in some of our quality improvement work in the UK when we're looking for patients. So we're posting them out to patients and getting their FEV1, FEV6. Not perfect, but enough to make enough of a diagnosis now and then review when the COVID settled down and we can actually do proper spirometry. So I don't know what you think about that as an approach.
Well, the Pico 6s aren't on PBS here. You can get a Pico 6 or a COP, the one where you put weight in, I think it is the other model. But in Australia, they came from, where'd they come from? They came from Boehringer. If you went to one of their workshops called the Clear program, then you got a free device of each type and a supply of devices. So I've got plenty, but I'm sure most people who haven't done those workshops wouldn't even have one in their surgery.
Okay. Great. Let's go back to the audit report. So let's go through this. So you're going to get the first bit is, this is the patients who got a diagnosis, who are high risk. The big thing is that those who haven't got a diagnosis. And so people will be given a list of all of those patients who've had frequent, so this is the patients here who not received an official diagnosis of their COPD. They have no asthma, but they actually have cough codes, flare-ups, lower respiratory infections, dyspnea coded, and then all of the patients will then be identified. So they could be brought in or flagged for next time you see them. What would be the best way of doing that, do you think, Russell? Do you think these patients would respond to a letter inviting them in, or a phone call, or do you think just flag it on the system for next time they turn up?
Well, I mean, flagging's easy. That can easily be done. Getting them to buy into a recall, I don't think the bland letters from the practice nurses saying, please make an appointment regarding a non-urgent result is very motivating. I think you'd have to have a more individualised invite as to why you wanted them to come in. Yeah. If you had the time and the effort and the energy and the enthusiasm to do that, then I think you would get a much better take-up rate, but still it wouldn't be great.
No, and I think that's it. It really has to be personalised, doesn't it? There's no question. We actually had a very good response rate when we did our program of screening in Aberdeen. We actually had a very, very high, it was around 50% of people came in. So we were actually pleasantly surprised. But we had stressed that we were going to do proper testing and try and make a diagnosis and potentially start people on treatment. So, because I think one of the reasons why people don't come is they just feel they're going to get a lecture on smoking. And that's always, even though they may need a lecture on smoking, it still is seen as one of the reasons not to come in.
And I mean, in the UK, it's free, whereas Australia, if they're a private patient, then they would be anticipating there's probably going to be some extra costs involved in you recalling them. So, you know, if I had someone I really wanted to engage with, I would be in their individualised letter saying this will be covered through Medicare. You won't have a large out-of-pocket just to try and get them on board.
Yeah, absolutely. Okay, so here's some of the comorbidities that existed in these patients. So, so this is sort of the practice here has got 13% of heart failure, a bit of, I mean, this is not full CKD, this is sort of 3 and worse. Osteoporosis in 16%, What do you think about this, and what do you think should have happened in the practice about this sort of types of comorbidities alongside?
Well, if you've got a high depressive illness, you've got a high kidney disease, you've got high heart failure, you've got what else? High osteoporosis. You don't want to be throwing too many courses of oral steroids at those cohort, and they're the ones that are going to suffer.
Yeah, absolutely. And I think that's really important. And I maybe wanted just to address the OCS use as part of rescue packs, etc. I think the OCS use in COPD, people don't tend to worry very much about it, but actually I think it's particularly worrying. There was one very large trial out of Canada a few years ago where they actually gave people action plans and packs of steroids and antibiotics to have at home versus the control arm who didn't. And their independent data monitoring ethics committee stopped the trial early because there was more deaths in one arm than the other. So they all got very excited thinking they'd proven that action plans worked. And of course, what was the result? It was actually the ones who got all the steroids had actually gone and died from the steroid side effects. So I think we do have to be very, very careful about our use of steroids. Not just COVID-19. I think it's a general issue for us. The other thing that I sort of mentioned earlier on was the heart failure issue. And should we, should these patients be treated just the same with their heart failure as normal? Because what we see in the databases is they're not treated the same. They get a lot less beta blockers. They get a lot less ARBs, etc. So just wondering what you think on that.
Well, according to my lunchtime detail yesterday from Novartis, Entresto is the cure for everything in cardiology. I think you can use beta blockers safely in COPD. I think you've got to get the heart under control, otherwise all your other therapies aren't going to be terribly flash if the heart failure is undertreated.
And what was interesting is in our database studies just published, we found that as I say, the heart failure, the COPD wasn't badly treated because they're so breathless. They get everyone keeps giving them more inhalers, but their heart failure was undertreated, and that's I think people's concern about the treatments there. And then what would be your threshold to start looking for things like osteoporosis in these patients? How low should it be?
I think it's got to be high on your suspicion list. I mean, if they're over 70, it's easy. If they've had the right amount of oral steroid, it's easy. Yeah. If they've had a fracture other than a finger or a rib or a toe, then it becomes a lot easier. Or otherwise it costs them, I forgot what it costs, 100 and something bucks.
Yeah. Okay. Then I've got a question here actually on long-term antibiotics and the use. So I think there's two things to maybe split here. So long-term antibiotics are virtually never recommended as a particular treatment for infection in patients with COPD. But, there's a big but here, there is data on macrolide antibiotics given low dose azithromycin 3 times a week in those patients who have chronic bronchitis phenotype and exacerbations. So they're producing lots of sputum and would be an optional add-on to LAMA-LABA or triple therapy. But because of the risk of side effects, I personally think they should only ever be started by a specialist. But I'd be interested to see what you think, Russell.
If I've got somebody who's actually, so if we're talking COPD now, if they're using their inhalers properly and they are using them, and particularly the bronchiectatic cohort. So if I've got a high resolution CT that shows they've got some bronchiectasis hiding along there, then I'll use it fairly routinely. I don't wait for a specialist to do it. The main problem in Australia is that azithromycin is not PBS. So if you're doing azithromycin 500 on a Monday, Wednesday, and a Friday, then they'll get it for about $26, $27 a month, I think it is, from a chemist warehouse. The other option from Peter Gibson's data is that erythromycin 250 every day is almost equally efficacious, but I see a much higher vomiting and nausea and potential diarrhea, gut side effects with the everyday dosing of erythromycin. So I normally get, when I explain that to the patient, they normally buy in and say, okay, I'll go to azithromycin 3 days a week. Thanks very much.
Has research looked at the reason people are not proactive with seeking help for COPD? How can we focus in on that? Is it just shame related to their condition being caused by smoking? Fear that they cannot cope without smoking, unlikely to respond well to treatment. So Russell and Kerry, I'll leave that one with you while I do a little IT look for slides.
Okay, what was the first bit of the question, David? What was the
People are
first
not
bit?
proactive in seeking help for their COPD.
Seeking help. Yeah. I'm happy to talk, Russell, if you like, since you've held the stage for me while I've been mucking around with it. I mean, certainly, people are quite nihilistic, and that's a concern that they put their cough and their other respiratory symptoms down to, oh, it's just my smoking. The doctor's going to give me a hassle again about giving up smoking, and you find that you do have to, be quite communicative with them and encouraging them and and focus on other aspects of care to start with, but the whole time, your aim is to try and get them to stop smoking. So how do you find it, Russell?
Yeah, I do get the occasional person who has the ultimate guilt trip, and I try and allay that if they've stopped. If they're still smoking, well, I might have a different approach, but I said, look, put all that behind us. You've got it. Let's just try and get you on the mend. So
I think it's the current smokers who, you really want to be trying to engage with those people, and you don't want them to not come and see us, and you feel like, that they they'll often say, oh, but every time I come, someone's going to give me a hassle about my smoking. It's a bit like, well, let's just keep plodding along and see how we go. And we know how tough it is, but we want you to to get the best outcomes for your health, and we'll do what we can to do that.
I give them look, there'll be a very, very short sermon. It'll only last 15 seconds. You shouldn't be doing it. That's fine. But the trouble is, while you're still smoking, you're asking me to go in against Muhammad Ali with both hands tied behind my back, because every medication I have in my kit bag, it will not give you the benefit that you want by going on to inhalers. But if you were to stop smoking and go onto the inhalers, you may well see some clinical improvement. I'd say, what do you want me to do? Do you want me to bring you down from Gympie and an hour drive on Holbrook Road every 3 months to say that I've got nothing else to add to your therapy, or do you want to get on board and we try and do something about it?
But it is tough. It is tough for people.
Yep.